that take a look at which area is the single longest region phase in terms, right? This is the passive ventricular filling phase. Passive ventricular filling is longer than any of these individual other phases. Why is this important? Because when your heart rate is less than 100 beats per minute, all we basically really need is passive filling. Active filling really is not as important, right? Now, what happens when you exercise though? When you exercise, and this is what it looks like, you know, the actual chart, if your heart rate is at 60 beats per minute. When you exercise, your heart rate is 2.5 times that a second. So instead of 1 beat every second, when your heart rate's at 60 beats per minute, it's 1 every second. Instead, when you're working out, it might go to 150 beats per minute or 2.5 times a second. When you really have 2.5 beats in 1 second, do we really have time for this very long passive filling? No, right? Active filling becomes more important then. So when we're at rest, all we really need is passive ventricular filling because there's so much time between your heartbeats. But when you are working out, when you're scared, when you're excited, any reason to increase your heart rate, when any of those conditions occur, what happens, right, is that the time period for passive filling severely decreases. Instead of this very long period, well, if our heart rate's faster, shouldn't I see another P wave? Instead of way over here, it should be much closer, right? If it's over here, we see P wave. Instead of way over here, if we see it much closer because we have increased heart rate, well, passive filling is so low, right? It's not much time for passive filling. That's when active filling becomes important. So atrial contractions, ejecting blood to the ventricles, are only important when we have high heart rates. At lower heart rate, almost all of that blood flow going from the left atrium to the left ventricle is due to just passive filling, just gravity, allowing blood to come from the left atrium to the left ventricle. That's enough. But when the heart rate increases, you do need this active filling. It becomes much more important. Now, get to know these volumes. End diastolic volume is the end volume at the end of ventricular diastole, meaning the ventricles are fully relaxed still, and now we're just starting to contract them. That's your maximum amount of blood in your left ventricle. And systolic volume is your leftover amount. You've ejected blood out, right here. Ejected all that blood out. And there's always a little left over. At rest, you ejected 70 milliliters, 55 is left over. So just a little bit more than half, and that's it, right? That leftover volume is called our end systolic volume. The name should help you. At the end of systole, what is a volume left over? Well, at the end of systole, that means you've ejected blood out. That's systole. So that end systolic volume is your leftover volume. Now, your stroke volume is how much you eject per contraction. Again, coming back here, we started at about 125. We ejected 70, and we're left with 55. The area underneath this light blue in the ejection phase, that's your stroke volume. Stroke volume is your end diastolic volume, 125, minus your end systolic volume, 55. So 125 minus 55, 70 mLs. So you only ejected 70 mLs, right? Now, one of the things we can do is measure something called our ejection fraction. Ejection fraction, usually in order to do this, I know we have our cardio technology programs, all right, and ultrasonography programs that do this. at downtown METC, and it's pretty cool how they are able to find out your ejection fraction. And what we're gonna do is unless you're, have parents that are having congestive heart failure, you never should have to worry about ejection fraction at your ages. At my age, a little bit older, right? Or if somebody had a previous MI, that's when we do these much more targeted lab values. The ejection fraction normally should be just slightly more than 50%. What ejection fraction is your stroke volume divided by your end diastolic volume. Meaning, right, our stroke volume, 70 milliliters. That's how much we ejected. That's on top. Divided by what we started with, 130. So if you have 70 divided by 130, I mean, we're talking about 52 to 54% ejection fraction. Meaning even in a good, healthy heart, we eject slightly more, and just slightly more than 50%. But the good news is, if you eject more than 50%, you'll have more ejected out than coming back. The problem would be when we have ejection fractions less than 50%. That means that when you eject blood out, more came back, right? There's more than what you ejected out, which is not good, right? Now, usually you're not even symptomatic though, unless you're less than 45%. So the thing is, your heart's able to cope with it. But when your ejection fraction is less than 45%, you become symptomatic. And that's when we start seeing the edema, pulmonary edema, generalized edema that we see with people with congestive heart failure. Right? Now, ventricular pressures. Blood pressure in the aorta, usually 90 to 100 millimeters of mercury. Blood pressure in the pulmonic trunk is about 20 millimeters of mercury. Keep in mind that this difference, right, does not mean that because the right side only has to go to 20 millimeters of mercury, that it ejects blood first, right? What we're gonna see is that because there's less muscle in the wall of the right ventricle, it takes just the same amount of time to go from 0 millimeters of mercury at diastole to 20 on the right side. It takes the exact amount of time as for the left side to go from 0 to about 100. So then the timing is the same. When we eject blood on the left side, should be at the very similar time as when we eject blood on the right side, even though there's a huge pressure difference between the two sides. The reason why? Well, the big pressure that we see on the left side is going to be negated by the amount of myocardium on the left side, meaning that the amount of heart muscle on the left side matches the pressure on the left side. So then it takes about 1/4 of a second for you to go from 0 to 90. At the same time, the amount of myocardium on the right side also matches its pressure. It takes that same 1/4 of a second to go from 0 to 20 on the right side. So then we have ejection from the right ventricle, ejection from the left ventricle occurring concurrently together. On each side, we should eject 70 mLs of blood. Makes sense, right? Even though we only show on this slide that we're ejecting from the left ventricle. Would it make sense? And I want you to think about it. Would it make sense if we didn't have the exact same numbers on the right side, right? If we didn't eject 70 mLs on the right side, that wouldn't make sense, right? The reason why is simple. If we have a mismatch in the stroke volumes, we have a sign that something's wrong, right? You might have start of congestive heart failure on either the right or the left side. That's the only reason why the stroke volumes on each side should be different. Right. Now, we will hopefully go and review the EKG here. On Anatomy and Physiology Revealed, I want to show you guys where the actual animations are that are slightly better. All right, heart sounds. Now, you should always, and right away, I know there's a problem with this picture, right? Right away, there's a problem here. Now, when you do go to see your doctor and they listen to your heart sounds, do not get embarrassed, right? There's one particular region that we want to listen to, and it's usually next to the left nipple area. So what a good doctor will do is listen to 4 different regions of your chest. Those 4 different areas corresponds to the best location to hear the valves. You have 4 valves, you have 4 regions, right? Any one of the valves can have an issue, and now we have an anomalous heart sound. So we have S1 and S2. S1 and S2 is due to the mitral and tricuspid. So here's your, all right, mitral valve, right? So, and here is your tricuspid valve. So the mitral valve, and I don't like the way this is, it should be over here a little bit, right? The mitral valve is around that left side right here, next to the manubrium, actually the body of the sternum here. And blood is going to go from the left atrium down to the left ventricle through the mitral valve. So where's the best area to hear any heart sounds caused by the mitral valve? Right where blood flow is going to go through, from left atrium down to the left ventricle. So near that left 5th through 7th intercostal space, that's when we hear the mitral valve, best. Now, the weird one is this, right? This is our first intercostal space, second, third, right? Between the second and third intercostal space on the right side, that's when we hear our aortic valve, right? So if you hear a doctor listening to the right side of your chest and you're wondering, what the hell is he listening to, right? Because the heart's on the left, right? Well, the reason why we listen on the right side is because of the way blood moves. When blood moves from your left ventricle up into the aorta, you project that sound towards the left side. And it's best heard by one of the main arteries that goes to the left, called the brachiocephalic trunk. So if you have a problem with the aortic valve, I can hear it best right here. So let's say I have a problem with my aortic valve when it closes. We call that an aortic, right? Or when it closes, we call it an aortic insufficiency. It doesn't close all the way. So we should hear it when it closes. That should be S2. We should hear it best on the right side at S2. We shouldn't hear it very good on the left. We shouldn't hear it very well at all down here on the left side. We should hear it best on the right side. There's a reason why we have to look and listen to all 4 regions. And what they're going to do is listen for S1 and S2 on that right second intercostal space. Then, all right, listen for S1 and S2 on the left intercostal space, second intercostal space. And then listen up for S1 and S2 at these 2 other regions. So the louder we hear it, the more likely it is to be that actual valve that is an issue. Right? Now, we don't have time to really discuss it, especially, I think I have a discussion of it in my actual lecture videos uploaded already. But when you're looking at this, right, yes, it is kind of weird. We listen to the right side, right? Yes, it can be uncomfortable that we might have to listen next to the breast area. And this is the weird one right here. Should you ever put a stethoscope on a bone? By the way, you should never put a stethoscope on the bone, all right? Should you hear anything if you put a stethoscope on your sternum? No, right? Because it's bone. Bone is not going to conduct that heart sound. It's going to prevent it. So what we see here for the tricuspid valve, you're usually going to move it slightly to the right, right? And you can hear it slightly to the right or slightly to the left. Never put your stethoscope, the bell, on the bone. You're not going to hear anything. So when I'm trying to hear the tricuspid valve, usually I move it to the left slightly, and it's in that the 5th left intercostal space, immediately next to the body of the sternum. Again, right, we're going to look at different areas for different heart sounds because they represent different valves. Right. Mean arterial pressure, or MAP. Here's what I'm going to do for you guys, right? Who wants a little bit of extra credit? If you get the question right, I want you guys to email it to me, right? And actually what I'm going to do, because there are so many people that are not on the class, that are not on the actual live stream, what I'm going to do is make it as a dynamic assignment, but for extra credit. So, all right, so what I want you to do is just going to be 2 questions, and it should help you review what we're studying in 20 and 21 for the test, right? What I want you to do is tell me, right, what does mean arterial pressure measure? What does it measure, right? I don't want, right, so the red dots are where the doctor should place it, right? The red dots are where the doctor should place it, except this one, right? Because the red dots here is on the sternum, which doesn't make sense. So I'm gonna actually discuss it with the publisher about this one. So it should be on the left 5th intercostal space. This one's a very similar level, but a little bit more lateral, right? That's when we hear the mitral valve. And again, all of these regions are supposed to be where blood is going through that valve. So as blood's going through that valve, right, you can hear it best as blood goes through it or as blood closes that valve. Now, in terms of the questions, and I'll write it down, right, in an assignment, it'll be under assignments, tests, and quizzes. What I want you to do is just look at the question, download it, and then re-upload it at the Blackboard site where you see the dynamic assignment. I don't need anything huge. Like for mean arterial pressure, I don't need the formula. Because if you look at this formula, does this formula explain anything to us? Mean arterial pressure is cardiac output times peripheral resistance. Can you imagine trying to explain that to a mother that son has some kind of low or high blood pressure, right? They have no idea what you're talking about. You need to sometimes understand the meaning behind these values. And that's what I want you to start with now. What is mean arterial pressure, right? It's actually very specific. And if you do a quick Google search, it's really not hard to kind of find out what it means. So the first one I want you to look up, what is mean arterial pressure actually measuring? I do not want, all right, something like this, where if I ask you, what does this mean? Could you explain it to me? Probably not. If you can't explain it to me, try to explain it and have a parent understand it. It's not going to happen. So I wanted you to use your own words. And it's actually much easier than the second question. The second question is, what does diastolic blood pressure measure? Systolic is left ventricular pressure at full contraction, the highest contraction possible. That's systolic blood pressure. Diastolic blood pressure, well, what does it measure? It doesn't measure left ventricular pressure at rest because that goes to 0. So a little hint. So I'll kind of, make a Word document, and if you get both questions, all right, you get 10 points added to your lecture exam for extra credit. Right? Now, let's talk about this one. I do want you to know what cardiac output is. Cardiac output is amount of blood pumped by the heart per minute. All right? So it's amount ejected out of the heart to the body in a 1-minute time span. Now, how do we get that value? Stroke volume, how much you eject with each beat, times how many beats per minute, heart rate. So stroke volume, 70 milliliters, is normally our stroke volume, right? That's what we saw over here. 70 mLs, normally our stroke volume. Now, let's say you're in good shape, right? So with each beat, I eject out 70 mLs per beat. That's my stroke volume. Now, my heart rate normally, let's say I'm in good shape, 60 beats per minute. What happens? Well, what is 60 times 70? About 4,200 mLs per minute. That's normal, right? So we're looking at cardiac output. I want you to understand, and I'm going to do a new share so I can use a whiteboard. Right? So we're looking at this, right? at cardiac output over here. Right? Cardiac output is, let's say, stroke volume over here. For some reason, that's not working. So it's stroke volume. Right? We do it. If I can't do it, that's fine. For some reason, this part doesn't work well, the whiteboard. So, all right, look at my other, videos for this one. All right, so you have 70 mLs per beat, and you have 60 beats per minute. So our normal healthy person should have a cardiac output of 4,200 milliliters per minute. We don't like using those big numbers. 4,200 milliliters is 4.2 liters per minute. All right, so at rest, 4.2 liters per minute isn't that bad. What happens when you exercise? Right? When you exercise, your heart rate goes from 60 to 150. That's a huge increase, right? So right away, when we exercise, our heart rate is going to allow us to increase our cardiac output at least that little bit, right? From 60 to 150, that's 2.5 times more. At the same time, the weird thing is this: when we exercise, our efficiency in the heart actually increases. So our stroke volume actually increases, which is weird, right? Normally stroke volume at rest, 70 mLs per beat, not very good. But when you exercise, even in people that are just weekend warriors, not like professional athletes, when you exercise, your stroke volume can easily double from 70 to 150. In elite athletes, it can triple from 70 beats or 70 mLs per beat to about 200 milliliters per beat. That's a huge increase. And what happened is when you have your stroke volume going from 70 to 150, let's say, right? That's actually pretty normal. So our stroke volume now is 150. And now we multiply it by our heart rate, which is also at 150 now because you're exercising. Our new cardiac output is massively bigger than what it was at rest. Now, at 150 for each, our new cardiac output is 22.5 liters per minute. We've gone from about 4 liters a minute to 22.5 liters. That is a maximal, that is a huge response to exercise. And it allows our heart to eject enough blood out. So then we can increase the work rate of our body. Yeah, I'm not writing anything. I can't write anything. Sorry about that. The whiteboard isn't working on this thing. So, I try to write on it. I don't think I can write on this. So I don't know why. I might have to talk to the people from Zoom, right? So what we're looking at here, right, is that we have this cardiac output, and maybe I'll try to use this. Okay. Let me see if this works. Give me 1 second. I'm gonna try to move this out so then we can see it a little bit better. All right, can you guys see me, this projection? A little bit here. Let me get this on this side. So what we're gonna see is this, right? So here's my white screen, right? And what we're gonna see is cardiac output over here, right? Now I'm sorry that it's kind of like inverted, but cardiac output is our stroke volume times our heart rate, right? Is there a way to make it so it's not inverted? I'll have to take a look. And what happens is, normally, if my cardiac output, right, normally stroke volume is 70 milliliters per beat. and my heart rate, 60 beats per minute. What happens is when I multiply these two, my normal cardiac output is like 4,200 milliliters per minute, or 4.2 liters per minute. So when we're looking at this right here, I want to just see if you guys, can I invert it? I can't. Right. So the numbers are kind of, right, I don't think there's a way of me doing it. So then in reverse.
Actually, it's fine.
Okay.
I can see it's right from where I can see.
Okay, perfect. All right. Now, what we're talking about with this is our normal cardiac output at rest. Right. That's pretty good by itself. What we're going to also see is when we start to exercise, what happens? When we start to exercise, we know our heart rate increases. Right? It was normally at 60. Well, because of exercise, it's not uncommon for it to go to 150 beats per minute. The weird thing is your stroke volume also increases, right? From 70, it can increase to 150 milliliters per beat as well. So when we exercise, both the stroke volume and the heart rate increases. So when you multiply that, 150 times 150, we're going to get about 22,500 milliliters per minute, or 22.5 liters per minute. Right? We went from 4.2 to 22. That's a 500% increase that can happen. That's huge, right? Now, the crazy thing is elite athletes like LeBron James. By the way, I don't think it's better than Michael Jordan, right? But when you talk about LeBron James, what we're gonna see is those guys, there's a reason why they're so elite. There's a reason why they're even better than even other people of similar size, is this, right? Normally people that are in great shape like that, at rest, their heart rate's actually really low. Have you ever noticed that when you get in good shape? I remember when I was younger, much younger, and I was wrestling. As I was a wrestler in high school and in college, right, I was in great shape. My heart rate, when I was having a surgery done, they said that my heart rate never went above a 45, right, which is good. What I'm trying to say is the better the shape you are, the lower your heart rate. So when you have elite athletes, it's not unheard of for the heart rate to be so low. It can be in the 30 to 40 beats per minute range. Crazy, right? What happens then? Well, what happens if you have a much longer period of filling? What happens is the heart is actually a little bit more enlarged, and at rest, their stroke volume is actually a little bit more than ours. Remember, normally for a normal individual, stroke volume, how much you ejected, is only 70 mLs per beat. For those elite athletes though, they can have stroke volumes at rest that approaches 120 mLs per beat, right? Meaning they're a little bit more efficient at rest than a normal person, which we expect, right? But that's offset because of how low their heart rate is. What happens? At rest, elite athletes, their cardiac output is actually pretty low, usually lower than ours. Remember, ours, 70 mLs per beat, 60 beats per minute for heart rate. We have a cardiac output of 4.2 liters a minute. For them, usually it's lower at rest, all right? It's not unheard of for them to be at like 3.5, 3.2, 3 liters per minute. The reason why is this, right? They actually cope with a little bit of anaerobic conditions at rest. But look what happens when they start to work out. When they start to work out, their heart rate goes from 60 also to 150. Their heart is also much stronger. And because it's bigger and stronger, where ours can go to maybe 150 mLs per beat, maybe 160, theirs can easily go to 200 mLs per beat. When we multiply them, what happens? You have 30,000 mLs per minute, or 30 liters per minute. That's a huge difference. Huge difference, right? At rest, 3.6 liters. When they're working out maximum, 30 liters per minute. There's no way a normal individual can get to 30 liters per minute, right? What it allows them to do with elite athletes, it allows elite athletes to not just cope with kind of a lowered oxygen content at rest, it also allows them to increase the values tremendously when they are working out, right? Now, we want what we call a greater, right? We want a greater amount of, we want a greater amount of cardiac reserve. So the cardiac reserve is a difference between our normal, quiet type of cardiac output when we're relaxed, meaning, you know, about 4 liters or so, and, right, what is the difference between the normal cardiac output at rest and our maximum cardiac output when we're exercising, right? Normally in the mid-20s, in some people, maybe even a little bit higher. In elite athletes, their cardiac output can be in the high 30s, 35, 36 liters per minute. That's a tremendous amount of blood you're moving, right? Now, again, the more blood you move, the more active you could be. Not only can you be more active, you can be active for a much longer period of time. So, of course, the greater the cardiac output, the better you should be kind of, you know, the better the response should be when you exercise, all right? Perfect. Now, for normal people like us that are like to work out, like to, you know, play basketball a little bit, maybe weekend warriors, well, our cardiac reserve is very important. We want a big cardiac reserve because it allows us to cope with stress. Now, with coronavirus, we know people that have cardiac reserves that are very low, right? Where their normal cardiac output at rest is very close to their maximum cardiac output. Those people that have that kind of very small band for cardiac reserve, they do terribly with this virus. This virus, we know, not just affects the heart and the lungs, but it really has a tremendous effect on the heart as well. So we want that high cardiac reserve. Now, what are some of the factors affecting mean arterial pressure? Review these. And, all right, one of the things that I will talk about are this, right? Let's see if I can find it, the next one, right? Intrinsic regulation of the heart. Understand what preload and afterload are. Preload, right? So intrinsic regulation means regulation of the heart where it is something that the heart controls by itself. It's not caused by the control in the brain. It's not caused by controls in your, you know, medulla oblongata. So these are intrinsic to the heart, results from normal characteristics of the heart, not on hormones or neuroregulation. So there's 2 terms I want you to know. One is called preload. Preload is the amount of stretch in the heart wall. You guys have all worked out, and when you were working out, you stretch out a little bit, right? Now, I use that example of in my 201 class. Many of you guys have done push-ups before, or done bench press, or something like that. And in the middle of it, you know, or you're doing squats. And after a couple sets, your legs started to tighten up, right? If you're doing squats. When your legs start to tighten up, what do? You try to stretch it out to kind of lengthen it again. There's a real reason why we try to stretch it out. And the real reason is this. And I do want you to think about it physically, what happens, right? And I want you to think about it this way. I'm gonna have the video up hopefully soon, right here. And what I want us to look at when we are taking a look at this is when you are contracting the muscle, the more you contract the muscle, the more the muscle shortens, right? So After the first set, you're doing squats. After the first set, it just shortens a little bit more. After second set, you're tired now, a little bit more fatigue. The muscle's even shorter. After third set, it's even shorter. So what do? Well, if you would contract the muscle when it's very short already, we know it's not at the optimal length, right? If you contract the muscle again for a fourth set and it's already shrunk, when you contract it next, you get a very weak contraction. So you have that urge then to stretch. As you stretch, you spread out the muscle fibers again, right? Increasing the space where you can contract and shorten. There's a need, especially that urge to stretch that muscle that you have worked out, right? The more you stretch it, the more you move it apart, the more actin and myosin can interact, the more space you have to shorten it again for the next cycle of contraction. That is what we call preload in the heart, right? Same thing happens in the heart. We want in the heart to stretch it out enough. As we stretch out those cardiac fibers, what happens? You stretch it out, more actin and myosin can interact. So then the next contraction will be stronger. Perfect. We call that preload. Preload is the preloading or stretching of the cardiac muscle. The main purpose is that you can then contract with greater force. So usually in terms of intrinsic regulation, preload is something that is a good factor. Assuming your heart is healthy, preload means more stretch. Preload then is going to increase the contraction strength. If your heart is not healthy, it's not good then, right? So what will cause more of your heart muscles to be stretched out with preload? More blood coming back. So the more blood we have coming back to the heart, we're going to see in chapter 21, most of the blood at rest, most of it will be stuck in the veins of our lower body. When you are at rest, you're resting. The veins aren't really moving blood from your lower limbs. But when you start to contract the muscles, let's say you're doing an elliptical machine, or you're walking, or you're jogging, right? In any of those active aerobic exercise activity, you're contracting the muscles of your leg. Contracting the muscles of the leg mobilizes blood that was stuck in the veins of your leg. So the more you contract those muscles, the more you mobilize the blood in the legs, the more you return it back to the heart. We call that increased venous return, right? So now we have more blood returning back to the heart. More blood returning back to the heart means more stretch of the heart. So the greater the blood flow back to the heart, the greater the preload, the greater the force of contraction, the more efficient the heart actually becomes. This is one of the reasons why when we work out, our heart actually becomes more efficient. Our ejection fraction actually goes from 54% at rest to in the mid 70s with contraction and with exercise. So preload is a good factor, as assuming your heart is healthy. Afterload is a bad factor. Afterload is pressure the contracting ventricles must produce to overcome the pressure in the aorta and move blood into the aorta, right? Heart is not as sensitive to this as it is to changes in preload. Afterload is a negative factor. Afterload is probably the best example I have to give you is to show you that, right, that picture before of that graph. Afterload is the amount of blood sitting on our aortic valve. Now, this is our aortic valve pressure right here. What would happen if instead of our aortic valve pressure being at 85 to 90, what happens if it's at 100? We have then increased the afterload. What would happen is I would have to increase pressure tremendously just to overcome the pressure in the aorta. Before, the aortic pressure is at 80. And now you have more blood resting on it, it's at 100. Well, what happens? You're going to stress out the heart a lot more, aren't you? Right? It's going to take more pressure in the left ventricle just to open the aortic valve. So you're going to really put a lot of pressure on the heart. The higher the afterload, the higher the aortic pressure, the higher the stress required just to open the aortic valve. The more stress you put on the left ventricle, the more likely it is to fail. Now, the good thing about left ventricle is that it can deal with small changes and even somewhat large changes in pressure, but it can only do so for such a long period of time, right? So here we kind of talk about preload and afterload. Again, preload proportional to the end diastolic volume. So preload is determined by how much blood we have right before we contract the ventricles. Makes sense, right? The more blood in the ventricles, the more stretch. The more stretch, the more preload, the greater the strength of contraction. That's one of the reasons why our heart is more efficient when we're working out than it is at rest. Right? Now, I want you to get to know these terms. Preload, afterload, end diastolic volume, end systolic volume, and this one, venous return. All right? Venous return means blood returning from the veins. That's all it means, right? So with venous return, we're looking at the more venous return usually is a sign of more activity. So the more activity we have, you're jogging, you're moving your arms, you're contracting those leg muscles rhythmically, right? You are then mobilizing blood in your veins. The more you mobilize blood in your veins, the more you return it back to the heart. The more you return it back to the heart, the more venous return we have, the more stretch we will see in the heart. The more stretch, the greater the strength of contraction, and the more efficient our contraction will become. Perfect. Again, preload is good, assuming everything else is healthy. Afterload, always bad. That's a pressure that must be overcome before the aortic and the pulmonic valve opens, right? In congestive heart failure, blood begins to remain in the ventricles, increasing the preload and the afterload. The only time when preload doesn't increase efficiency is if there's an unhealthy heart, CHF, right? Now, left ventricular failure usually results in water in the lungs, pulmonary edema. Now, usually when people have CHF, congestive heart failure, it starts off as either right-sided or left-sided, right? Usually not both sides are affected initially. Eventually though, near the end, right, both sides will be affected. But initially, usually one side is affected more than the other. And usually it's this right ventricular failure that occurs first. With failure in the right ventricle, right, with any time you have failure, blood starts to pool up in that area. So when the right ventricle fails, the right ventricle fills up with blood first, then the right atrium, and then the inferior vena cava. Superior vena cava, because of gravity, doesn't really, right, give you a lot of blood filling from your upper body. But where you have that failure, you will have a backup of blood, right, from that point on. So if the right ventricle is one that fails first, then we will see generalized edema or anasarca. You're going to see ascites, right? Some of you guys might have seen ascites before. And we see ascites with people that have, what just happened? All right, I try to end it. All right, we see ascites in people that have.
We can't. Dr. Lou, we can't see anything.
Okay, let me see. Can you see it now?
No, it's just the whiteboard. Oh, we can see now.
Okay, so in terms of the anasarca, all right, and ascites is spelled like this. It looks like ascites, right? But it's pronounced ascites. That's an abdominal edema that we see with people with really end stage or moderate stage liver failure, right? We do see it people with right ventricular failure as well. Left ventricular failure, you see normally pulmonary edema, right? Water buildup. Eventually, the only thing we can treat, the only thing we can do with people with end stage CHF is to give them a new heart, right? A heart replacement, and that's about it, right? Now, one of the things that we do do with people with CHF, and you're probably wondering why we give them this, is we give them lots of oxygen, right? Especially if it's a right ventricle that fails first, and usually it is the first one that fails. Why do we give people with CHF, primarily right ventricular failure, oxygen? It's because of this. The greater the amount of oxygen in the lungs, the lower the pressure, right? So what we're gonna see, if I give somebody lots of oxygen, I vasodilate the blood vessels from the pulmonary artery. Vasodilating them means I increase the size of the blood vessels, decreasing the pressure required to move blood through it. As we decrease the blood pressure even more by giving you 100% oxygen, I can decrease the right ventricular pressure required to move blood into the pulmonary arteries. So then I decrease the stress on the right ventricle. That's one of the reasons why we give oxygen to people that have right ventricular failure, right? It's an indirect way of helping treat it. Now, extrinsic regulation, we have of the heart, parasympathetic stimulation. Remember, parasympathetic is rest and digest, supplied by the vagus nerve. The main purpose then is to decrease the heart rate. Whereas sympathetic, or fight or flight, and you guys have been scared before. When you're scared, not only do you feel your heart rate increases, but it feels like your heart is just pulsing out of your chest, right? The reason why is this. When you're scared, you have sympathetic stimulation. The sympathetic stimulation innervates both your SA node and your AV node. Why is it important that it innervates both? By innervating, we mean it controls, right? By controlling and innervating the SA node, we can increase your heart rate. At the same time, by innervating your AV node, we can increase the force of contraction. So then our blood pressure can increase. That is what causes us to feel like our chest is just pounding, or our heart is pounding out of our chest. It's because in sympathetic drive, the AV node is triggered, and that goes to the ventricular myocardium, and it allows us to have that bounding feeling in our chest. So then with sympathetic stimulation, we see both an increase in the heart rate and the force of contraction, different than in parasympathetic. Parasympathetic, we just decrease the heart rate. We don't really affect the force of contraction because the vagus nerve only goes to the SA node. Right. Heart receptors and the heart and homeostasis, baroreceptors monitor blood pressure. More importantly, sudden changes in blood pressure. These baroreceptors are good for sudden changes. They're going to go to the medulla, right? And when there's a big increase in blood pressure, what we're going to do is, right, actually affect the heart rate, and that's it, right? These are not really good in controlling your blood pressure. In other words, if these were really good in controlling your blood pressure, would we have high blood pressure, hypertension, seen in about 60% of our population in America? No, right? These baroreceptors are good for sudden increases or decreases in blood pressure. Sudden being the big one, right? And what they'll do is adjust the heart rate in response. Sometimes, if it's lower, we can kind of hopefully, right, adjust the blood pressure. But usually the response to any increase or decrease in blood pressure affects the heart rate more than blood pressure. Okay, so you guys have probably seen these slides before, and this is a homeostasis slide. What happens when your blood pressure increases? Then baroreceptors in the carotid artery will then activate, causing the SA node and the heart rate, all right, and the SA node and the cardiac muscle to respond. Then heart rate and stroke volume decreases. Notice that it kind of affects blood pressure, but not really, right? It's better when we're going in reverse right here, right? Because when we go in reverse right here and your blood pressure starts to drop, then we can stimulate the sympathetic nervous system. When we can stimulate the sympathetic nervous system, We can increase epinephrine and norepinephrine. We can stimulate the SA node and the AV node. We can then increase heart rate and blood pressure. So when it's going like down and then homeostasis brings it up, that's a more efficient drive. Right. So review those. And what I'm going to do now, right? The rest of this, just review on your own. What I want to do now is go through a little bit of anatomy and physiology reveal, right? So give me 1 second and we will see if we can do the anatomy and physiology revealed so you guys can look at where things are. Can you guys see the screen, the Google screen?
Yes.
Perfect. All right, then I don't have to, all right. So when we're looking at this, we'll go through our Blackboard site. And we go through our anatomy and physiology revealed. What I want you guys to look at here, and I will, add an assignment for chapter 20, just for you guys to review, right? It's going to be about 50 some questions, and that's about it, right? Hopefully, somebody had asked about having those practice questions being assigned. So, it's kind of a hard balance because if I put too many of them on, then it becomes like busy work, especially when we have so many exams. I don't want to have too much of that. But I will have some for you guys to use as a review. So let's talk about the cadaver dissection tool right here. Now, when we're looking at this right here, I'm just going to stop recording it.